I start? Okay, let me share my screen. Can everyone see my screen okay and hear me okay? Perfect. Okay, so thank you, Johannes, for the introduction. My name is Meg. I'm currently a fifth-year medical student at the University of Cambridge, and today I'm just going to talk to you a little bit more about the research that we were doing in 2 years ago, on telemedicine for people experiencing homelessness. So, as Johannes briefly mentioned, this was an intervention that was brought about by Dameter as a way to tackle providing a good quality of care in terms of GP consultations during a time where it was seen as dangerous or unsafe for patients to have face-to-face consultations. So no longer were we able to provide outreach and all these other services. So the question was, how do we get a good quality of service to our homeless population in Cambridge without causing them to have to come in for face-to-face consultations? And the solution Dameter came up with was this telemedicine service, where he commissioned a mobile phone to use as a pilot study in one of the COVID hotels at the time. And this telephone was to be used to be shared around by different patients to enable them to have these video consultations directly with Dameter and the rest of his team. And we trialed this over a period of 1 month to see basically what was working and what wasn't, and whether this was an intervention that could become part of the GP practice going forwards, or whether this was something that really wasn't working for patients. So during this time, over the period of 1 month where it was trialed, we conducted a series of interviews with stakeholders such as GPs, nurses and other people involved, and service users as well, to see what their opinions were. And these are a couple of the main findings, which I'll talk in more depth about today. The first one, interesting one, is that we saw increased access to healthcare and fewer episodes of do not attends. And this was actually really brilliant to see. We actually saw the number of patients that did not attend fall from 23% to 11% during the 1 month period. And that we saw greater engagement, particularly from our most entrenched populations, we'll touch on the reason for those in just a second. The other aspect we saw benefits from was improved communication. So mainly we saw that video consultations tended to be better than telephone consultations, but obviously face-to-face was still the gold standard, and we'll explore that a little bit more later. However, with any kind of new technology, there will be barriers, and these were primarily revolving around the technological aspects, education and privacy. Okay, so firstly, increased access. So what we found is that video consults actually enabled our participants to have better engagement with healthcare services. And these are a few quotes from our key workers who were present at the time. And what they found in particular was that video consultations actually eliminated the need for patients to travel to their appointments. And this was particularly beneficial for patients with mobility issues who potentially were in a wheelchair or couldn't walk quite so far. For the first time, these patients were actually able to take effectively a face-to-face consultation in the comfort of the hostel or their home. And which meant that for the first time, we found that many of these individuals actually began attending their appointments and being able to be followed up, which was really exciting news. The second group of people that benefited particularly from video consultations were those with anxiety and depression. And there are a couple of individuals that we interviewed that mentioned that video consultations were actually better for them than telephone consultations, which were a source of more anxiety. Yet it was far easier than having to step outside of their home, outside of the comfort of the hostel, to have a consultation with the GP. So as a result of all of this, as I mentioned before, the rates of attendance increased exponentially. So we went from do not attends from 23% to 11%, and actually continued engagement from patients who would particularly normally not engage at all. Secondly, in terms of communication, we really wanted to compare the effects of video consultation to telephone, which was used primarily during the pandemic, and face-to-face communication. Now, from the literature and from our interviews with patients and GPs, we found there were a number of limitations to telephone consultations. Very often, poor volume and poor phone signal prevented communication. And it was far more difficult very often to build up a rapport or a relationship over a telephone consultation where you weren't able to, where you had a lack of that nonverbal communication. In comparison, the benefits of video consultations actually allows you to, having that video aspect brings back that nonverbal communication and use of body language, which was not only beneficial for the doctors to help assess patients' overall well-being, but also meant that patients felt more able to express themselves, which, as you can see here, was quoted by one of our health professionals. However, there are a number of limitations to video consultations. Firstly, there are only certain scenarios where video consultations will be beneficial. And these are scenarios where you do not require physical examination. So anything like dermatology reviews, or where a physical respiratory examination or cardiovascular examination is required, video consultations are not a good alternative. But in the scenario where an examination is not needed, particularly for mental health consults or for very simple physical health problems, video consultations could be a good alternative. And for many patients, they are actually preferred. However, one thing we do need to take into account is that the video screen is usually very limited, so you miss that aspect where you see the patient walking into the room. And as the quote says here, very often what you see on video is not the full picture for that patient. So based on all of these, our recommendations were to include video consultations as another tool in the toolbox of different types of consultations you can use, but to try and find guidelines to use them appropriately to make sure that video consultations wouldn't add extra stress or concern or worry in places where they were not meant to be used. Okay, and finally, the barriers. And these are, as I mentioned before, these are mainly around technology, infrastructure, and education. So firstly, in terms of the technological environment, video consultations do require more time to set up than, say, a telephone consultation. And for communication to be effective, several conditions must be met, and that includes good internet connection, adequate phone volume, and camera resolution. And I'm sure all of you have had at least one experience of a video call, either with a friend or family member, where the video quality has been terrible and it's been really difficult to actually hear what the other person's saying or see them clearly. And that can really affect the quality of the consultation and the quality of the rapport that you can build. Secondly is infrastructure. So like any GP, like any medical conversation or consultation, you want to be able to do it in a space that feels private and secure and safe, because very often the information you're imparting is very personal, and sometimes for patients they feel it's quite embarrassing. So ensuring that there is a private space to conduct the video consultations is critical, and whether that's within the patient's own room or whether that's a separate private space to allow those consultations to take place, that both of those are really important to allow patients to feel they're able to open up and talk freely. The final aspect, which if anything felt as if it was the most critical to ensuring the success of this program, was education and referral pathways. So one of the main critiques we had with video consultations was that many people, both in terms of staff and also from the patient side, felt unfamiliar with video calls and less comfortable with the technology. And for patients, this was in the form of a lack of technology literacy, particularly for older patients who felt wary and uncomfortable with the idea of using a video consultation. Whereas for staff members, because they felt less familiar with the program and setting up, it meant they were less likely to wish to use video consults as a method of talking to their patients. Now, both of these can be mitigated, hopefully, with the implementation of education to enable patients to ask questions about what the technology is and how it works, and be shown clearly about how to use it. But on the staff side as well, to have clear training sessions for all stakeholders so they're aware and comfortable with how to use the technology. In addition to this, having support workers who are able to facilitate consultations for patients who feel less comfortable with using technology and a support worker on hand in case anything goes wrong during the consultation from the staff side would be really useful in making people feel more comfortable with this new, with the new utilization of video consultations. The final aspect of this was referral pathways. And interestingly, during our study, what we saw is that very few patients seem to be taking up video consultations initially. And one of the primary reasons for this is that, that we were fed back is that many of them weren't sure who to talk to actually ask for one of these video appointments. So therefore, establishing clear referral pathways that are both easy to maintain and also private to allow patients to directly refer to the GP is really important. And ensuring that these pathways cater for those who are comfortable with digital technology and those who are not is really, really important as well. Okay. So based on all of these, we came up with the three main conclusions and recommendations. Firstly, from all our research, we saw that video consultations actually had made a huge benefit to improving access to healthcare, particularly for those most entrenched individuals. However, as we've discussed, it really does depend on the right design and right infrastructure with adequate training. So that is looking at potentially larger phone screens to allow participants with who struggle with their vision to see the screen more clearly, and ensuring that the microphone is loud enough so that patients can hear the doctor clearly and can be heard by the doctor on the other side. In addition to this, all staff stakeholders must be trained to use the technology, and this includes the other equipment that was provided, such as a pulse oximeter, blood pressure monitor, etc., for taking basic observations. And finally, communication must be maintained. And this is in the form of sharing records appropriately between organizations to ensure that if a patient moves from one area to another, that the communication and consultations can be shifted across that place. Secondly, we need to design a service with inclusivity and continuity in mind. So just as we've talked about, creating those pathways to ensure that patients can refer easily and in a way that's private for those GP appointments. One of the things we did actually come up with and might be interesting in talking about later in the question section was this idea of a text-in 24-hour service, which was mentioned by a couple of our stakeholders as a way to promote engagement in general, not just for video consultations, but also for booking all other kinds of appointments as well. And the second aspect of this was continuity of care. Very often where video consultations were less successful, or in general consultations were less successful, were where patients were placed with a GP that was unfamiliar to them, where they didn't have a long-standing relationship. So regardless of if this technology is implemented, it's really important to ensure that patients remain with the same GP that they feel comfortable with, in order to ensure that they're able to open up appropriately and feel that there is that continuity of care there. Finally, is this idea of a feedback and review process. So this was an initial pilot study, but from the success of it, as Damita might be able to talk about later, we were looking into expanding it further to Winter Comfort and possibly other services within Cambridge. And in order to do this effectively, it will be really important to have a continuous feedback and review process to see what is working and what isn't with video consultations, and possibly a local co-production group meeting as well. Thank you so much. That is everything I was going to talk about today. I'm sorry for talking quite quickly, and I'm happy to take any questions. Thank you very much.
Thanks so much, Ina. I think given that we're a small group, anyone feel free to jump in with any questions or raise a hand or type, like whatever works for you. And just to let you know, we'll put the report as well as the presentation online on the website. I'm going to put it to the chat. And the recording of the session, which I'm going to stop now.